worry about it again. We don't want to roar the shower.
Testing.
What are you testing?
You should have said checking your
Checking
dates.
the babies. That's what you say. You're not checking
Newborn
the
premature
scores.
babies, not scores.
Oh my God, I'm not ready.
Yeah,
You can't hear you.
That's a break.
Up here to learn.
And have a break.
Best of luck with
I
that.
have
But
a
let's
break.
just say, hands up who thinks he's a selfish bastard.
Oh,
Just the men then.
We'll see who's selfish and shouldn't.
What do you think I'm up to?
Here's the thing. When we do rotation, we can't really find the end of range too easy because we're just twisting right down through the whole neck. Okay, so we're not going to get that end of range, but I didn't mean that, I'm sorry. We're not going to get that end of range. Right? So what we're going to do is using this cradle grip, we're going to rotate down. Okay, so let's say for example I want to treat the left hand side. We're going to rotate away, then we're going to slide bend towards and use that little fulcrum in there, and then I'm going to go back to the rotation away, and now all of a sudden I've got a little barrier. Do you see that? There's a little barrier in there now, and I can mobilize in a grade 4. Okay, so then we rotate away, side bend towards, and rotate away. Then I'm going to do an upslope on the left hand side. From your side, if you want to upslope this side here, treat the right side. Do it again, same thing. We rotate until I start to feel a bit of rotation at my finger there. So catch me there. Yeah. Rotate to there. Then I'm going to side bend up like so. Adjust a little bit, then go back to rotation. And now I have a barrier, a bit of resistance. And I can rotate. And to do the oscillation at that barrier, I'm going to use a supination, pronation, not a big elbow flexion extension. It's this.
That's all. Great.
Like that. Yeah. Shift like that.
And is this upslope? Sorry.
That's the upslope.
Sorry, you're not treating at the end of rotation area. Is that okay for BVI? Because you bring the side bend, you're not bringing it off.
Explain to me why it's not.
Explain to me.
I'm answering your question with a question.
Okay. You
Sorry, sir.
but you're not going to that.
So it's a great point. Okay, so let's have a little look. Right, what two arteries get in trouble with the VBI? What is VBI really? What is it now? What's the new umbrella term that we're trying to bring in for VBI?
CAD,
CAD. So what two blood vessels are involved?
ICA and
Carotid
PVI.
and the vertebral artery. Lovely. So what movements affect them at what level of the spine?
Extension and rotation.
Extension, rotation, and mainly rotation. So exactly extension, putatively extension, but fairly well established is rotation. So if I rotate to the left, what's happening to the vertebral artery and the internal carotid artery? What's happening? It's getting deformed where?
On the left.
So the right one here is getting deformed. As the C1, the lateral mass of C1 rotates around, it pulls that out of the way, but the artery has to come back in that way. So it pulls a big deformation into that. Further information found in Kerry and Taylor. Can we read it? No, but it's worthwhile rereading, that's why. Even look at it, if you look at the back note, or the neck note, you see the diagram from Kerry and Taylor on the rock, you see that. So when you do the rotation, because actually it's in Greaves that runs from there, but you cause a big deformation in that there. Okay, and that narrows the canthus of that artery so it can carry less blood through. So, is end of range, someone has VBI signs or high risk factors, anything from that as dull occipital headache, high blood pressure, cranial nerve signs, any of that stuff going on, 5Ds, 3Ns, all that kind of stuff, any of those symptoms at all going on, is this technique indicated? No, simple as. And so basically you're answering your own question, right? You know, yeah. But just talking through, that's why. So what I'd say is this, for your exam and for general day-to-day life, we need to know that because what can we do? If we can't do end-range rotation or sustained end-range rotation, if we think that's maybe a little bit dicey in the patient, what can we do? What doesn't affect it?
Translation.
Mulligan snags aren't going to affect it. What about nags? Yeah. Nags aren't going to do it. What about PAs? Face-to-face entertainment. Yeah. What about using flexion or flexion anyway? Is that going to be okay? Using flexion? Yeah, it is. So the stuff we can do, and if we understand exactly the hemodynamics, that part of it, we can kind of work around that. Does that make sense? I'm sorry for teasing that out like that and answering your question with a question, but that's why it is, so we can work around it a little bit. So absolutely, this would not be indicated for EBI at all. If there's any signs at all, this is out, gapping is out.
So Terry, is side bending out then if you think about it because you're stretching it?
Side bending, you know, a little bit. It's a grey scale. If someone's got a lot of signs, a lot of risk factors, I'm 80, I've had 3 heart attacks, my blood pressure is through the roof, even though it's kind of getting controlled by medication. Should I be treated in the first place? Well, let's say I am. And then am I going to do end range side bending? No. If I'm 30, I don't have high blood pressure, I don't have an occipital headache, I have a bit of neck stiffness, but I get a little bit dizzy sometimes.
Yeah, that was the case this morning.
Yeah, a little bit dizzy. Could I side bend then? Yeah, sure. No problem at all. Because they're going to answer the phone, aren't they? You're not going to turn the car. So that's fine. So it's a grey scale, isn't it? And it's about that judgment.
But if they
call.
were getting a little bit dizzy, you still avoid rotation, but perhaps use gapping or something.
Could use gapping, could use translations, you know. You could use it, and use it sparingly. You could test a little bit. Use it sparingly. But I'd be avoiding end of range very torquey techniques. If someone's getting dizziness at all, because I said to you with the case before, a woman who was 32 years of age, had a bad enough car crash, had a lot of osteophytes in her neck, and we did a bit of EBI on her. I think it was just sustained rotation, and she was nauseous, and she was up on the table lying down for about 20 minutes, and I was calling the ambulance. So, you know, that was it. But that was coming in with just a bit of neck pain. So you get those cases too. Not to freak out about, just so you know how to manage that. When it comes into it, no problem. We know why it's happening. That's fine. We just did rotation. We've done the test first, so we've provoked some symptoms in the test. No problem. Hop up on the table, have a relax. Shift you off into A&E, so you can spend 100 hours in there, she's not about it. But it's fair enough. Rather you find out in a safe environment in your clinic, then, you know, she strokes out somewhere else, isn't it? Do you know what I mean? So we get those things well, but it's a great step. Do you know what I mean? We all get a bit of dizziness. And again, dizziness doesn't just come from vertebral artery insufficiency, do you know what I mean? Or carotid artery insufficiency. There's other causes for that as well, vestibular causes, so on and so forth. So it doesn't necessarily mean that it's positive for BBI if someone gets dizziness on rotation.
So Terry, do you just mean sustain end range rotation, or do you mean just
that's
introducing?
That's the dodgy one. Sustained end range rotation is going to be the dodgy one for the arteries, isn't it? You know, extension to some extent as well could be problematic as well. But sustained end range one, and then with kind of ballistic movements, that theoretically increases the risk a little bit again.
Okay.
You know, because we could shake it.
So what about like a snag into rotation briefly?
I'd
and
have
back
no
out?
problem with that for a second. You know, because they're in control of it. They're going to the normal range of rotation, and then say you do 3 or 4 reps. Is that giving any dizziness? No, it's fine. Okay.
Okay.
Another 3 or 4 reps, and then you can see how that goes. Because they're going to be, they're in charge of the movement. It's an active movement. You know, you're assisting it. Again, if they've got dull occipital headache, they've got a sunken eye, and they can't feel half their face, you shouldn't be treating them anyway. You know, that way. So it's a grey scale between that patient that will come into you that has distinct cardinal signs and the patient that has maybe a bit of lightheadedness sometimes when they don't eat. What's that? You know, so it's a grey scale. Any remember what I was doing? So here we go again. Cradle hold. So upslope to left, we're going to rotate away, side bend towards. Now here's where people go wrong. See that little fulcrum I'm putting in there? And you can adjust a little bit there as well to get to that, there we go, to get to that end of range position there. Okay? So you want to make a barrier. So if I just rotate, there's no barrier, right? And now if I rotate, lock that in a little bit. Now there's a barrier. Can you feel that a little different there, can you?
Mm-hmm.
There's a little barrier in there now, okay, we put in. And that's where we put the extra twist in, so we can localize it to whatever level we want. Otherwise we're just rotating the whole thing down. Make sense? So I'm going to practice it. It's the best way. Practice, and practice, and practice.